Good morning, students. Today I am going to talk about congenital talipes equinovarus. Now, this is a very common foot deformity which we see in the newborn. So, we are going to learn more about this problem today. So, what are our learning objectives? We want to learn about what is CTEV, that is the congenital talipes equinovarus. How is it caused? What are the etiological factors? What is the pathological anatomy? What are the tissues, bones? What is the pathology in them? How does the child presents? How, when you examine the child, what are the findings? That is the clinical features. Then about this deformity, what are the different grades, the severity? How do we radiologically evaluate the patient? And lastly, how do we manage, treat the case? So, what is CTEV? CTEV in common language is also called clubfoot deformity. Now, this clubfoot deformity is normally seen 1 in every 1000 live births. So, it is not very uncommon. This condition is more commonly seen in male children. And congenital means since birth. Talipes equinovarus, they are Latin words. Talipes means talus, which pertains to ankle, and pes, which pertains to foot. So, it is a deformity which is related to ankle and foot. Equino means horse-like. So, the foot looks like horse-like. A horse walks on its toes. So, that is the similarity of the appearance of the children's feet with the horse. That is why it is called equinus. And varus means turned inwards. The whole foot appears to be turned medially or inwards. So, before we understand the deformity, the clubfoot deformity, let me tell you something, or you recapitulate what does a normal foot look like, how the bones look like. So, what we have here is a foot, a right foot. These are the metatarsals, cuneiforms, navicular, talus, cuboid and calcaneus. So, the deformities are around the joints and the ankle joint. So, this metatarso cuneiform joint is called the there is a joint at which there is an adduction deformity. So, forefoot deformity takes place around this joint, and this is forefoot. Now, this is all midfoot, which includes intercuneiform joints, cuneiform cuboid joint and naviculo-cuneiform joints. At this midfoot level, there is an exaggerated cavus deformity, that is, there is a high arch deformity. And then hindfoot, which consists of talonavicular joint and calcaneo-cuboid joint. So, this whole hindfoot joint is turned inwards, resulting in varus deformity. Lastly, there is the ankle joint, the tibio-talar joint, and this is fixed in plantar flexion, so giving an equinus appearance to the foot. So, clubfoot or the CTEV is characterized by 4 main deformities, and they are at 4 different levels. So, let us try to understand it. Forefoot, जो आगे का पैर है, which I showed you the tarso-metatarsal joint. There is this adduction deformity. There is the adduction deformity. Midfoot, as we have seen in the diagram, is talonavicular joint, intercuneiform joint, and there is a cavus deformity, that is high arch deformity. And lastly, the hindfoot, which has subtalar joint and the calcaneo-cuboid joint, there is inversion or the varus deformity. And at the ankle joint, that is the tibio-talar joint, there is fixed plantar flexion resulting in equinus deformity. So, what are the basically different deformities in the foot? In clubfoot, we only have equino-varo-cavus. So, a child may be in equinus, that is fixed plantar flexion. The opposite of it is calcaneus. The foot may be turned inwards, which is called varus. The opposite is valgus. There is cavus or the high arch, deformity which results from the midfoot deformity. Opposite of it is planus. So in CTEV or club foot, we have equino-cavovarus deformity, and we must differentiate between a equinus calcaneus, a varus valgus, and a cavus and planus foot. In some of the feet, there is flattening of the transverse arch, which results in a splay foot. Now, as I told you, there are 4 deformities. These 4 deformities mainly are the cavus, adduction, varus, and equinus, and we can remember them by this word CAVE, cave. So cavus is exaggerated medial longitudinal arch, adduction forefoot adduction, varus hind foot varus, and equinus, that is a fixed plantar flexion at the ankle joint. And how does it appear clinically? See here, high arch. See this, the foot is turned inwards, so there is adduction. Whereas if you see the leg and foot from posterior side, that is the midline, the whole heel is turned inside, that is there is varus deformity. And as you can see here, the whole foot is plantar flexed, that is the equinus deformity. Now, why this club foot is caused? Most of the time, we do not know any reason. So this is a primary or idiopathic variety. But at other times, you do have some pathology associated with the CTEV, which is called a secondary CTEV, and it is associated with some underlying cause. So our main description for the diagnosis and the treatment would basically be on the idiopathic variety or the primary variety of the club foot. Secondary CTEV sometimes is also associated with many syndromes, the commonest of them being arthrogryposis multiplex congenita, in which many joints, the major joints of the limbs are affected and deformed and stiff, dystrophic dysplasia, Streeter syndrome, where there are constriction bands which you can see in the forearm or in the legs, and many other syndromes. Similarly, another group of disorder which constitutes the secondary CTEV group is a paralytic disorder. Any condition which involves the peripheral nerves or the spine can result in foot deformities. So included in this group are poliomyelitis, spina bifida, myelodysplasia, and Friedreich's ataxia. So here are some examples of syndromic and paralytic disorders which may cause clubfoot deformity. Here you see these constriction bands, these are amniotic band syndrome. And now this is a caudal regression syndrome in which the neurology is affected and the child may get clubfoot deformity. Here you see the opposite of club, that is the calcaneus deformity. There is plantar flexion of the foot. So we must differentiate between plantar flexion and the dorsiflexion of foot. This is dorsiflexed. In club foot there is plantar flexion. Here there is tibial agenesis, poor development of the tibial bone. Obviously it will result into contracture of the tissues and a club foot may result. Charcot-Marie tooth disease, again a neurological involvement resulting in the club foot. As you can see, there is varus heel. You can see the forefoot is adducted. The heel is high, that is there is equinus. Now, why the idiopathic foot is caused? What is the etiology? So 3 theories have been proposed how the club foot is caused. The first and the foremost is the mechanical theory. It says that there is increased intrauterine pressure. So what happens? The fetus has got its feet against the uterine wall, and when this foot is forced against the uterine wall, it will take up a equinus and varus deformity. The second theory is that of the ischemic theory. The blood supply to the calf muscles is affected. It is there is decreased blood supply, which results in fibrous tissue generation, which results into the contraction of the tendo Achilles, resulting in clubfoot deformity. And lastly, the genetic theory says that there is some genetically related disturbance in the development of the foot. The bones are not normally developed, and so the clubfoot deformity results. Now we will discuss about the pathological anatomy. We know about the etiological factors. Actually, अब क्या कौन से tissues हैं जो abnormal हैं, जिनकी वजह से ये deformity होती है? And if we identify that pathology, we now understand the principles how to treat this disease. So in pathology, all these structures are abnormal: bones, muscles and tendons, ligaments, joints, capsule. Now, which bones are more abnormal? Which group of muscles, ligaments, joint, capsule is contracted, is abnormal? We learned that. So bones, basically bones of the hind foot and the midfoot are grossly deformed. The first and the foremost being talus. This is a normal appearing talus as seen from top, as seen from side. What happens in clubfoot deformity? The head and neck is deviated medially and downwards. So this is a normal bone, and the head and neck gets directed medially and downwards. Talus bone as such becomes much smaller. The navicular bone, which is articulating with the talar head to make the talonavicular joint, is at fault. The navicular bone slips down medially and downwards. So this is a right foot, medial side, lateral side. This is the navicular bone, this is the talar head. It is slipping medially and downwards. The talar head is slipping downwards and the navicular is going medially. Then the calcaneum. The calcaneum bone also becomes small. All the bones are smaller than the normal size, with the result that the whole foot is smaller as compared to the normal side. Calcaneum is also medially rotated, and its anterior portion comes to lie beneath the head of the talus, and it gets locked there, resulting in varus and equinus deformity. The cuboid bone, which is articulating with the anterior end of the calcaneum, also gets subluxated over the calcaneal head. Now coming to the muscles and tendons. Since there is equinus deformity, there is varus and adduction deformity, all the structures, musculotendinous structures, capsules, etc., which are on the posterior side, which are on the medial side, which are on the inferior side, get contractures. So posteriorly there is gastrosoleus muscle, which becomes fibrotic. The tendo Achilles, which gets inserted here, pulls up the calcaneum, resulting in equinus deformity. So tendo Achilles is posteriorly is contracted. On the medial side, there are these three structures, tendons of the muscles. Just behind the medial malleolus is the tibialis posterior. Posterior to it is flexor digitorum longus muscle, which is responsible for the flexion movement of the toes, and lastly is the flexor hallucis longus, which flexes the big toe. So all these structures are contracted, and in the treatment we either have to stretch it or to lengthen the muscles. Also important is that here when we open it, we see a dense fibrous fibrocartilage structure which encases all these tendons and results in contracture that needs excision whenever we are doing an open surgery. So that is called Henry's knot, knot of Henry. Coming to the capsules and ligaments, posteriorly you have the ankle joint, tibio-talar joint, subtalar joint. Now both these capsules of the joints are contracted. On to the lateral side, posterior talofibular joint and calcaneofibular ligament, they are also contracted. On the medial side, there is the deltoid ligament, the spring ligament which supports the talar head, and talonavicular joint capsule. These are all contracted and need release. Inferiorly, there is plantar ligament and the plantar fascia. Because of the equinus positioning of the foot, these two structures are contracted and need stretching. Further, on the lateral side, there is the bifurcate ligament which arises from the calcaneum bone. One of the slip gets inserted on the talus and the other on the cuboid. So this ligament is also contracted. And the ligament between the talus and the calcaneum, which is the interosseous talocalcaneal ligament, this is also contracted and requires release. I have told you about the master knot of Henry, which is lying on the medial side of the foot near the navicular. This needs excision whenever we are doing a open surgery. Skin changes. Now, because the adaptive changes that the skin takes place because of the constant deformity of the foot, what happens to the skin? There are deep creases on the medial side, and there are shortening of the medial side of the sole. You see the creases. You see the medial border of the foot is shorter. The lateral border of the foot becomes longer. There are dimples on the lateral aspect, and there is callosities and bursa. When the child is neglected, he doesn't get treatment. He walks on the lateral border of the foot. So the longer lateral border of the foot gets callosities and bursal development. And sometimes in long-standing neglected cases, there are vascular changes. There may be hypoplasia or absence of the dorsalis pedis and anterior tibial artery. Now coming to the clinical features. As such, the foot of the newborn, the affected side, appears small. Besides this, the heel is small and in equinus. If we look at the heel over here and compare it with the normal side, this will appear small and into equinus. This is the leg and the foot is in the equinus. Foot is also inverted. So if we see it from the posterior side, what we find is the heel is, the whole foot is inverted or in varus position. There are deep creases and on medial and posterior aspect. So this is the medial aspect. You see deep creases on the medial aspect. Lateral border is long, curved. Medial border has got creases. Abnormal thin calf muscles. If we look from the posterior side, we will find that this calf is smaller in circumference as compared to the normal size. And all these deformities, the equinus, the varus and the adduction, they may get corrected passively if we force the foot into correction. They may get corrected, or sometimes they are rigid and they may not get corrected. So there is a variable lack of correctability in this deformity. Now how do we classify? Classification of club foot is important, so we know what type or grade of club foot is it. Is it amenable to treatment conservatively or not? So first and foremost is your CUMMIN's classification. He has classified the feet depending upon when the child presents to you, depending upon what do you find on examination of the foot. So first is the supple foot. Here the foot can be brought to normal position and all joints are mobile. So the treatment in this case is very simple. All you need to do is bracing to protect the foot, and sometimes the child comes neglected, that is after 1 year. This is called a neglected foot. Relapsed when the deformities are corrected but reappear. A recurrent club foot is when it is treated correctly but then the relapse occurs. And resistant when no correction is there after conservative treatment. So one of the most important system is then PIRANI scoring system. This is a simple and reliable system to determine severity and monitoring. So 6 signs are assessed. The 3 signs are in the midfoot and 3 signs are in the hindfoot. And depending upon the severity, abnormality of each of these signs, we score 0 if there is no deformity, it is normal, partial 0.5, and abnormal, that is 1. So in all we have a maximum 6 points. The total score varies from 0 to 6. and is the sum of the points that the child scores, the foot scores on midfoot and hindfoot. So what are these signs? On the midfoot, presence of medial creases. If there are too many, too deep, the score is 1. If there is none, the score is 0. Curved lateral border of the foot. We had seen in the picture how the lateral border is curved. If it is not curved, 0 point. If it is excessively curved, 1. Intermediate is 0.5. There is lateral head of talus gets uncovered. If it is we can feel the whole of the talar head, it's 0.1. If none, 0. Similarly, on the posterior side, there are 3 signs. Presence of posterior creases, we see just above the heel. Empty heel seen. When we push in our finger on the calcaneum, on the heel, we may feel bone, we may not feel. If we do not feel any bone, 1. If we feel the bone, 0. And rigid ankle equinus. That is, we try to correct the equinus. If we can correct it, 0. If we cannot correct it, 1. Now coming to the radiographic examination. Basically, this is done from recording of the point of view. So we take X-rays and record some angles. Talocalcaneal angle is recorded on AP and lateral view. Tibiocalcaneal angle is recorded on the lateral view, and talus and the first metatarsal angle is again recorded in the AP view. So normally the angle is between 35 to 50 degree. Talocalcaneal angle, whether it is AP view or the lateral view. But this angle is much decreased in clubfoot. Here is an example of the lateral view angle. You see this angle, approximately 35. Much decreased, or the lines become parallel in case of the clubfoot. This is 42 degrees. So now, so far we have discussed about the etiology, the clinical presentation, and the radiography. We will take up how to manage this clubfoot, how to treat in our next part. Thank you.